start with, I would like to welcome everybody to this afternoon ceremony. And by saying this, I open officially this academic ceremony in which Mr. Mehmet TÖNGE will defend his academic thesis entitled Complications in Deep Brain Stimulation Surgery, Avoidance and Management. May I invite you, Mr. Candidate, to present a summary of your studies and the conclusion of your thesis in the next 50 minutes, and I'd like to give you the word.
Dear highly esteemed Prorector, dear Defense Committee members, my supervisors, online and on-site participants, colleagues, friends, and family. In the next 15 minutes, I will present an overview of my thesis entitled Complications in Deep Brain Stimulation Surgery, Avoidance and Management. Since its first introduction by Alim Louis Benabid and Pierre Polak in 1987, the deep brain stimulation surgery, the modern deep brain stimulation surgery, has been performed on thousands of patients worldwide for various indications like essential tremor, Parkinson's disease, dystonia, OCD, and epilepsy. And many more other studies are on the way, even in clinical and experimental fields. With the increasing number of the implantations, we began to face with increasing number of complications as expected. We can classify these complications into the surgical procedural, the hardware-related complications, and the stimulation-induced side effects. Within the scope of this doctoral thesis, we focused on one of the most feared complications of deep brain stimulation or DBS surgery, the intracerebral hemorrhage or ICH. And in the next chapter, we focused on the targeting issues to compare the indirect targeting with the direct targeting and their effect on the final electrode position. And in the next chapter, we focused on the most common hardware-related complication, which is infection, and we implemented a cost analysis for different scenarios. And in the next chapter, we focused on a stimulation-induced side effect, the cognitive decline, and we explored its relation with the surgical characteristics. And in the finally last chapter, we focused on a more recent hot topic in the field, the perilid edema. Starting with the ICH, its incidence is around 3% according to meta-analysis data during DBS surgery, and it's a potential cause of morbidity and mortality. It can present asymptomatic or symptomatic, and the risk factors are not clearly established. So our research question was whether if the single electrode recording or multiple electrode recording affect the ICH incidence and also the single-dose gadolinium versus double-dose gadolinium in stereotactic targeting affect this issue. Our study turned out with an incidence of 4 out of 220 patients of ICH, which is 1.8 per patient, 0.9 per surgical site, 0.3 per recording electrode, and 0.2 per brain penetration. And at the end, we didn't find any relationship between ICH risk and the age and gender, nor the single versus multiple microelectrode recording, and neither with the single versus double dose gadolinium use. In the next chapter, we focused on the targeting. So, in the classical stereotactic targeting, we use the atlas-based coordinates even for the STN in DBS. That is, we have some exact points inside the brain, which is MCP, and according to MCP, we delineate the estimated target. So, thanks to the advancements in the MRI technology, with the high-resolution T2 images, we became able to more precisely see the anatomical structures, including the STN, as you can see in here. So this shifted us to target this structure with a direct visualization, which is called direct targeting. So our research question was, is there any effect of this shift from indirect to direct targeting on final implanted electrode position? As you can see on the left-hand side, there is a red dot on the left. That is the estimated point of the STN target according to the atlas-based data on T1 image. In the middle, you see its projection on the T2 image. And on the right-hand side, you will see it is a corrected version of the target according to the direct targeting data on the MRI. So we found three key outcomes from this study. One is the number of MER trajectories has decreased by approximately 1 microelectrode per patient. The second is the laterality of the target improved significantly. And the last output was the central trajectory has been chosen as final position in more patients. However, this is statistically insignificant, but still it was a remarkable finding. In the next chapter, we focused on the infection. Well, the deep brain stimulation system consists of three components. One is the stimulation electrode, the other is the extension cable, and the other is the IPG, also called as the battery. The incidence of a hardware-related infection in DBS surgery varies greatly in the literature, but it's mostly a slow infection. It takes months to years to show up, and the majority involves the extension part and the IPG, as shown on the photographs. So, in this case, when we have an infection in a DBS patient, we usually have two scenarios. In the first scenario, we can upfront go for removal of the entire system and then wait for another 3-6 months to recover and the bacterial eradication, and then consider reimplanting the system. On the other hand, another scenario, we can start with an antibiotic treatment attempt, then after infection resolves, then everything is okay. But if fails, we can follow the first scenario again. So all of these issues have an economical burden. We investigated this in our study. We made a cost study across the infection cases, and our incidence was 3.5 in the cohort. So when we look at the different management strategies, we found that attempting to treat the patient initially with the antibiotic treatment rather than removing the system decreases the overall cost of the treatment by 12%. And this saves almost around 3,000 euros per patient in a generalized population of patients. And the next chapter we focused on the cognitive decline, as I mentioned. The cognitive decline, for the cognitive decline, the STN is a little bit accused in the literature as a side effect in long term. The etiology is unclear. The higher age, the existence of axial symptoms, the larger volume tissue activated, the microlesion effect, and also stimulation parameters, and the leads location within the STN itself are accused for this, but none is clearly proven yet. The STN is a small structure, as you know, and it is a tripartite nucleus roughly. It is a limbic, associative, and motor part. And in DBS surgery, for the motor effects, we target the desire to target the motor part of the STN and to avoid the side effects. So in our research, we investigated the surgical characteristics of the patients and the MER numbers and the STN length covered by the electrode and the trajectory angles, and checked whether if there is an effect on the cognitive decline. So our research showed that the patients have a significant cognitive decline following 1 year after DBS. However, the effect size is small. But with the surgical characteristic, the only related factor was the right coronal trajectory angle, and it was related with the TMTB domain of the cognitive functioning, which was also represented as a small effect size in our cohort. So the number of the patients were also small, the affected patients. At the end, we didn't find any relation with MER number and STN length with the cognitive decline overall. Lastly, we focused on paralead edema. The perilead edema is a field of edema developing around the electrode after DBS surgery at any time. And it is more likely to be reversible in most cases in the literature. And incidence of the symptomatic ones is around 3% in the available literature. So our main questions were, research questions were, what is the incidence and possible predisposing factors for developing perilead edema, and what are the management strategies? So we designed a retrospective study analysis, and we had a cohort of 710 patients from the last 6 years, primarily implanted for various indications with DBS. So we found 28 patients there, which is equal to almost 4% incidence, and it is 2.4% per lead. The only significant predisposing factor was diabetes, and also the Versailles genus R16 battery was found to be related with this development in our univariate regression analysis. We didn't find any relation with other variables. So in all the cases, this condition was fully reversible and didn't require a system removal. These are some examples from the cohort. We had 4 cystic perilead edema cases. You see their images in here with the red arrows. And here is an interesting case with an acute presentation on day 2 after surgery. Patient developed a perilead edema on the right side, and on the 9th day, the patient developed another edema on the other side, and they both recovered at the end. And this is a massive perilead edema patient. You see on the right side an edema, and it's extending to brainstem and temporal area. This patient required an ICU admission, but at the end, he also recovered fully. So, the final conclusions of this thesis can be summarized as the microrecording should not be avoided due to the bleeding risk when necessary. The use of double dose of gadolinium is not necessary in surgical planning. Direct targeting method leads to less brain penetration while estimating a better central trajectory and also improving the laterality. Initial antibiotic treatment attempt without system removal reduces the overall cost of DBS infection management and can prevent the patient from loss of stimulation effect, period. The surgical trajectory passing through the right frontal lobe can be associated with a mild cognitive decline in ST and DBS surgery. Diabetes is a significant risk factor for symptomatic perilead edema development. And finally, the clinical and radiological relief from perilead edema can take months, but even it takes longer. At the end, almost all of them, at least in our cohort, recovered without any further surgical intervention. Thank you for your attention. And now I finished my words. I'll give the next words to highly esteemed Prorector.
Thank you very much, Mr. Candidate. Thank you very much, Mr. TÖNGE. I hope I pronounce it correctly. And I noticed you give the opposition 2 additional minutes for discussions, and we are always appreciate this. Before we're going to start, I would like, and since this is an online event, I will also introduce several members who are present here. Of course, I introduce first myself. I'm the Prorector, Professor Steinbusch, and I'm assisted by Professor Sandring as my secretary at this event. But much more important is the promotions team who sit opposite of me. And the promotions team consists of 2 people. It's Dr. Jan Shahi, he's Associate Professor in Neurosurgery, and the first promoter is Professor Temel, who is Professor in Neurosurgery. Saying this, I also like to mention to the audience, the whole event will be on site. We have no onliners to speak in this little official language, and we have 6 members who will ask questions to the candidate. And without further ado, I'm going to start, and I would like to give the first word, the first possibility for an opposition to Professor Linden. Professor Linden is leading in the Department of Translation Neuroscience and also the director of the School of Mental Health and Neuroscience, and I'd like to give him the opportunity to oppose.
Thank you, Prorector. Dear candidate, first of all, I'd like to thank you for your very clear presentation on this clinically very important topic. I'd like to congratulate you on the very clear and, as far as I can assess as a psychiatrist, clinically very important work that you've done under the guidance of your promotion team. I would also like to ask you some questions, but first of all, I would like to ask one of your paranymphs to come forward and read Proposition 9 for us. Proposition 9, please.
No wind favors him who has no destined port.
Thank you. So, dear candidate, as an academic neurosurgeon, what is your destined port?
I'm still searching for the best I can do. As you mentioned, highly esteemed opponent. As you mentioned that as a neurosurgeon, we are combining the clinical with the science, and we are trying to drive them all together. So in my case, I'm still trying to give as much as benefit I can give to my patients on one side, and I'm trying to learn as much as I can, and I'm trying to also develop for the science for the future. That's my plan.
And as we're talking about the future, perhaps, and although I think, and that will be discussed by the neurosurgeons on the panel in more detail later on, I believe, you're making the case that essentially DBS is a safe operation, at least if it's performed in experienced hands and in the appropriately experienced and equipped center. Do you think that in 10, 20, 30 years we'll still be discussing and seeing the same numbers or even increasing numbers of DBS interventions? Or do you think that something perhaps even safer, semi-invasive, will replace it at some point, at least for some indications?
Highly esteemed opponent, thank you for your wise compliments and questions. So, in my opinion, and also the future perspective studies show the similar outcomes, that the DBS is evolving. So when we compare it with for example, 30 years ago, now the systems we use are not the same. We now have the systems, they are capable of recording the patient's data, and in the next step we are getting an adaptive systems. So it is more tailored, becoming more tailored. So it's becoming, I think, less invasive. But also, along with the DBS classical approach, other techniques are on the way, like minimally invasive techniques. There are many studies on different fields, like endovascular stimulation, like magnetothermal stimulation, and much more. So we'll see all together. But with this concept, I think in 10 years later, we will not be doing the same thing.
Thank you. And perhaps one final question, more specifically related to your thesis, again, from my background as a psychiatrist, with an interest in clinical deep brain stimulation. In Chapter 2, you looked at the clinical records of patients, of implantations. You had relatively few implantations, for example, in the nucleus accumbens. Whereas you had many implantations in the subthalamic nucleus and thalamus, for example. And you concluded in your sample, I think, that there was no factor on bleeding risk, for example, as per electrode location or implantation site, although the literature had suggested perhaps some other effects. Now, this paper was published a few years ago. Now, with looking at the literature as you see it and your own experience, is it still the case that you would say the side effect profile is pretty much the same wherever you have your target site, or are there differences?
Thank you for this question. Well, the study was performed, it's been a time, and that patient cohort is a little bit changed now. But for the targets, I agree with you that there is a really controversy among the literature. Some previous literature was suggesting that, for example, the pallidum is more risky than the STN in terms of bleeding. But in the next studies, in the next larger meta-analysis showed vice versa. For the psychiatric targets, they are not as common used as the movement disorder targets. Maybe there is not so much sufficient data to make a statement about their individual risks. But some of them have more deeper locations within the brain and more close with the vessels. But also, on the other hand, the imaging technologies are evolving. We can better visualize the vessels, we can better visualize the anatomy. So I think in the near future, we will expect to have less bleeding complications, maybe.
Thank you very much. That's a very clear answer. Thank you. And I give the word back to the pro-rector.
Thank you very much. The opposition now will be continued by Professor Akalan. He is professor in neurosurgery. And now I have to read carefully. It's from Istanbul Medipol University in Istanbul in Turkey. And first of all, I would like to thank you that you came all the way from Turkey here, I'm sorry, to this event. And I would like to give you the opportunity to discuss with the candidate.
Okay. Thank you very much. It's my honor to be here and to witness this ceremony. First of all, I would like to thank and congratulate Dr. TÖNGE for the clear and timely presentation. I'd like to ask a few questions from the more neurosurgical side, starting with the intracerebral hemorrhage. I understand that, and I congratulate all the team that they have quite a low percentage of hemorrhage, but still there are. First of all, as far as you are doing more direct procedures under MRI, sometimes with double contrast, do you think going back with your cases with hemorrhage and again analyze it through the preoperative MRs, that what you have missed in doing that and what had caused the hemorrhage?
Highly esteemed opponent, thank you for your question and encouraging comments. In that cohort, there were only 4 patients among 220 patients. And one patient had double dose contrast and the other 3 had single. So maybe it is not so easy to make a statement with these numbers from the statistical point of view. But the basic technical targeting technique was all similar among all of them, because all those patients were operated with the same, following the same surgical rules. This study maybe can be a good candidate for further meta-analysis, and even it did. For example, last year one paper published having more than 30,000 patients also cited this study and these patients. Itself, maybe this study is not enough to make some conclusions, but as a part of some meta-analysis, it becomes more significant.
Okay. Another question would be, again, with the direct methods, do you feel that there will be conflicts with neuroradiologists, neurologists, and neurosurgeons in appreciating the target at all?
Thank you. Well, the STN segmentation is also still a debate. I have mentioned that STN is tripartite, but in the recent studies we see it is divided into 6 parts, maybe. And there are still some areas with the ambiguous functions. when we target the visible STN precisely, we cannot propagate that we targeted the right motor STN. That's why most surgeons are combining it with the electrophysiological findings and deciding on whether to place the final electrode. But with this perspective, I totally agree with you, because with the contrast of the images, if you play a little bit with them, you will see that the STN size is growing and becoming smaller. So making a decision, there are some rules to follow that. For example, the red nucleus borders is a rule, but it may change from one to another.
Okay, thank you. Again, you mentioned cognitive decline after the implantation within 1 year or so. How can you differentiate that, whether it's the natural course of the disease or the procedure you're doing?
Thank you for this very accurate question. I totally agree with you. Our group was only consisting the patients undergone DBS surgery. In order to compare this, we would also need another control group consisting of the patients without DBS surgery. We didn't have it. And in the higher ages, we see that the cognitive decline really happens in the course of the Parkinson's disease. And we can, just with this study, we can only compare it with the available literature. And among the other parameters, when we compare them, we found in some domains, basically, the decline. But it was also subtle.
Okay. The last question would be the ages of the patients. Do you think that any of these complications would be less, or the results would be better if you could do the procedure earlier than the usual common procedures now?
Thank you. This is an approach. It is more and more getting popularized. There was a study published 6-7 years ago. It's an early STIM study. It was suggesting that the performing surgery in the early stages of the Parkinson's disease, for example, may be related with better outcomes in the future before the permanent effects happen and also the systemic risks show up. But results are still a little bit a topic of debate now. We will see in the long-term follow-ups.
Okay, I think that's all. Thank you very much.
Thank you very much. Then the opposition will be continued with Professor Elmachi. We remain in Turkey, and he is professor and the chair of the Department of Neurosurgery at Deliberation University. I'm sorry to say this. Also in Istanbul, and I like to invite him also to have a discussion with the candidate. I'd like to give you the word.
Thank you. Firstly, I would like to very happy to be here and my honor. Also, I would like to thank the candidate, Dr. TÖNGE, regarding his very nice presentation and dissertation. I would like to be grateful, dear candidate, if you could clarify a few points regarding basically management of the intracerebral hemorrhage. As a neurosurgeon, I would like to be focus on a little bit more than your dissertation. First one, what are your criteria for deciding on hematoma evacuation, and which surgical techniques do you prefer in such scenario? Please.
Highly esteemed opponent, thank you for your encouraging comments and questions. In that study, there were 4 patients, and one had undergone evacuation of the hematoma. But it was a big hematoma and the patient had too much systemic problems. Then the patient was lost. But when we look at the literature, as mentioned also in the thesis, that the management of the intracerebral hemorrhages after DBS surgery is almost identical with the, any intracerebral hemorrhage in our neurosurgical practice. The only difference is the existence of the electrode there and the system there. So in a more recent study published by Bouvens, van der Vils and colleagues, they had hemorrhages they operated, and the approach was almost similar with the, our classical intracerebral hemorrhage approach, while trying to preserve the DBS system as much as possible. In the intracerebral hemorrhage, it cannot be easy all the time possible, and it's not necessary actually, because the target is also if affected by the hemorrhage. But for the subdural hemorrhage, I had 3 experiences. When we remove the hematoma, then we see the electrode turns back to its original position. It's another finding out of the scope of this thesis, but the management is similar.
Do you use stereotactic evacuation or open surgery? Little bit, please explain how do you decide it? Open surgery or stereotactic evacuation of the hematoma? A little bit more.
Well, thank you. I think this is a little bit out of scope of this thesis, but my personal point in this is we performed with microsurgery, microscopic surgery, while visualizing the electrode and everything, the system, trying to preserve it. But endoscopic, I have no experience, and even in this study, we had no experience about endoscopic evacuation.
Okay, thank you. And second question is, in cases where a patient with implanted DBS experiences an intracerebral hemorrhage, how is the device managed? I would like to ask about consider removing it entirely, or do you opt for delayed reactivation or something?
Sorry, excuse me, can I have the question?
Yeah, we have a patient, implanted device he or she has, and if we see there is the hemorrhage, intracerebral hemorrhage, how we manage the device? Is that necessity of the remove the device, or place the device at the same position and to reactivation at the delayed condition?
Okay, thank you very much. I think in this case, the most of the time this hemorrhage occurs around the tip of the electrode, at that area, deep area. So in this scenario, we need to remove the electrode if we will evacuate the hematoma, because it's interparenchymal. So in most of these cases, there are not so much cases actually in the literature reported like this, but in few cases, there is some sustained lesion effect following hematoma. For example, that's one scenario. And maybe the underlying movement disorder can progress to other components. If the surrounding tissue is affected, it may become from a Parkinson's tremor to Holmes tremor and combined tremor if the surrounding structures are involved in the hematoma. So I think it would be better to decide on what to do after the patient is stabilized and time has passed after incident.
Okay, thank you so much.
Then the opposition will be continued by Professor van Sandbrink. Professor van Sandbrink is professor in spinal neurosurgery, at our university, and I'd like to give him the word too.
Thank you, Mr. Prorector. First of all, I want to congratulate you with finishing your thesis. In this congratulations, I want to incorporate your supervising team, your family, friends, and all who attributed to this. So I read the thesis and I was very happy. It was a very practical thesis, so even a spine surgeon can understand it. Then when you advance in reading it, and I came to the general discussion, and then I was a bit confused or maybe a bit disappointed. Then you summarize the characteristics of an optimal neurosurgeon in page 91. And then surgical indications, operative techniques, post-operative patient care, management of potential acute and long-term complications are the main themes of an optimal neurosurgeon, to your opinion. And then, in the last paragraph of the general discussions, you learned a lot of this thesis. A lot, again, about indications, surgical planning, image techniques, implanted hardware, stimulation parameters. And then I asked myself, did you forget chapter 4? Then it is dealing about cost effectiveness. Isn't it important for an optimal neurosurgeon? What do you think about it?
Highly esteemed opponent, thank you for your comments and question. Well, yeah, I agree with you that I checked it and we haven't mentioned it appropriately. But we valorized it and we included it into impact. As you mentioned, that the cost analysis is important while performing a treatment. We all need to consider it. But our first priority is always the patient and their health. Maybe the cost is a second, but still an important issue. I needed to mention it maybe more frequently.
Okay, I'm happy with that answer. And then I asked myself, is there, maybe you forgot it, but can you elaborate on the maybe difference of the Eurasian perspective in cost effectiveness and the West European perspective? Is there a difference, or do you think it is all the same all over the world, especially Eurasian or West European?
Oh, thank you. For example, in my country, we have a social system covering the health expenses, and also there are other options, some insurances, some self-payments, and etc. So when conducting a treatment on the patient, like a big surgical treatment, we all discuss these aspects with the patients and inform them about the possible complications.
So in your country, the patients have to pay it for themselves. The very expensive implant is very expensive, or isn't it?
Yeah, depends on the insurance state.
Okay.
It can vary between individuals. But yeah, I think there are similar issues with the European point of view.
Is it in your country also a challenge that there is graying of the population and the costs are rising of healthcare, and that you have to watch for this and you have to keep a good balance in between expenditure and what you gain for it? Is it for you? Is it in your country a topic?
Well, I don't think recently. There's no limitation for the institutions to perform this kind of surgeries or the other types of surgeries. But for these highly specialized surgeries, we do have the committees within the hospitals and academic hospitals. We decide all together what is the best for the patient.
So there is no budget for you? So no plafond in the budget?
No, the institutions don't have their own budgets. They're all in a pool.
Okay, that's interesting. Then it is quite different from our country, where there is a lot of stress on cost effectiveness and what do we get for our expenditure. So then I want to go on. I want to focus on chapter 4, of course, then it is about cost effectiveness. And then you stress that you're in your conclusion, and you said it in your presentation also, that it is better in perspective of costs to do first, in case of an infection, to treat the patient with antibiotics. Can you defend this proposition to me, and did you incorporate all kind of costs, or how do you look at this?
Thank you. Well, incorporating all the costs is really difficult, because when we consider all the costs during that time, it also affects the individual himself and also the family and his profession. There is a loss of occupational employment, and we need to consider all of them. But this study was focused mostly on the hospital part and the treatment algorithm expenses.
Did you count for the real costs or the estimated costs?
These are actually the real costs. They're acquired from the Dutch Health Authority tariffs, and also they are acquired from the Maastricht University costs.
But also all people stayed for 5 days in the hospital, or then you counted for 5 days?
Yeah, that was a standard approach those time. In that part of the study, for example, the antibiotic treatment patients has a lay day of 14 days in this study. Nowadays, the infection approach is also evolved. They don't prefer to lay down the patient 2 weeks in the hospital anymore. They mostly prefer 2-3 days in the hospital, and then their guidelines are evolving. But for that time of period, it was the approach which we included into study. Well, we need to include all the expenses. But on the other side, there is one expense for the patient with the upfront system removal. That is the loss of stimulation effect. And besides its health and symptom part, it also has reflections on the daily living of the patient and his employment.
I fully agree with you. So isn't it more realistic to incorporate such a societal perspective than not only for looking to direct costs who are in the hospital, made in the hospital, but isn't it much more scientific that you incorporate a societal perspective? All those side effects which you mentioned. What is your opinion about this?
Thank you. This study needs to be proved with larger cohorts, because as you see in the study, there are only 13 infection cases among 11 patients. It's a very low number. But, for example, one patient has failed from antibiotic therapy. The outcome of this study would completely change. But this study established a model for the future studies. And for example, a more recent study, they published 20 patients, and still the ratio was similar with the upfront removal and antibiotic treatment.
But it is not all about the ratio you mentioned. It's also about societal. So when you would repeat a cost-effectiveness analysis, would you do it in this way again, or would you choose for another method?
Okay, thank you. Maybe we need to go more in detail, considering the other cost aspects of the real life living. But I have no more.
Of course, you have no more time, but it is nice to have a future perspective and to go back to your promoter and maybe advise him to do it in another way. Thank you for your answers. I give back the word to the pro-rector.
Thank you very much. Then the opposition will be continued by Dr. Akkermans. She is assistant professor at the Department of Neurosurgery, and I'd like to give her the word.
Thank you, Pro-Rector. Dear PhD candidate, thank you for inviting me to take part of this Corona. And I want to express my appreciation for this 10-year journey between Turkey and Netherlands. Also, my congratulations to you and your supervising team. And we share the same vision in our daily neurosurgical practice, to avoid complications in deep brain stimulation surgery. And I think every surgeon or every clinician will agree on that. But there are some complications, and you described it in chapter 6 about the symptomatic perilead edema. And the reported incidence of that is 0.4% until 100%. What do you think? What is the reason of this high incidence or low incidence, the very wide range?
Esteemed opponent, thank you for your comments and question. I totally agree with you. The incidence range is really wide, from 0.4 to 100. The more incidence reporting studies are mostly considering the non-asymptomatic ones and symptomatic ones altogether. So the 100% study has 19 cases. It was from Borellini and colleagues published, and it was a prospective study. They performed MRI in every DBS patients between 1 and 3 weeks after surgery, and they detected some perilead edema at some point. So that's why the number of that study is too high. So with the lowest number of indications, they can be skipping maybe some patients, because in our routine follow-up protocols, we follow the patients with the stimulation parameters and medications, and we try to adjust the balance between them. And if something is getting worse, then we first try to adjust these parameters. The point takes us to radiology, is most of the time irresponsive patients to adjustments or sudden worsenings. In this case, we mostly diagnose this entity. So that may be underestimating the real number of this condition.
So you think in your cohort you have an underestimation of the perilead edema in your group?
Thank you. Well, we can still have. We don't know it, but at least that study covers the last 6 years. Mm-hmm. And the follow-up protocol was more standardized, and the radiological follow-up was more frequently being performed to the patients. For example, before that, there are also another 600 plus cases, and there were only 3 perilead edema cases among them. And that is why we thought that we were underestimating these cases. And later on, the MRIs became easier to approach. Patients became MR conditional, and the radiological scans were more prioritized by us. Then we started to diagnose maybe more.
Okay. Thank you. In the discussion, you quote that none of the theories about perilead edema fully account for the variety of the presentations of PLE. And what do you think is the most plausible theory about this complication?
Thank you. From this study and the literature, not clear yet still, but the strongest theory, I think, is the inflammation theory. Because all they have their oppositions now. Because we can see this entity even 6 hours after surgery or 5 years after surgery. There are reports on this. So this eliminates the microtrauma hypothesis and the other acute hypothesis. The infection markers are negative, so this proves that this is not an infection. The venous infarction theory, it doesn't fit into this because it is reversible and it doesn't fit into the vascular supply fields. So there is few cases in the literature. They have perilead edema caused by the higher stimulation parameters and amplitude, and when lowered, the edema has regressed. That's an interesting finding again. But I think the strongest hypothesis is nowadays is the inflammation theory.
Okay, and you're a scientist. You've done a lot of research. If you have the opportunity and time, probably, how would you set up your research about this topic? What kind of research you are willing to do to prove in this theory?
Thank you. Well, some attempts have been done for proving whether if this is an inflammatory condition or not. For example, in some cystic cases, some authors have aspired the cysts and they have analyzed the contents in terms of immunoglobulin G and the others, but they still didn't reach to an inflammatory endpoint yet.
Do you think you need more CT scans or MRI scans during the follow-up period? Do you need some CSF research during surgery? What do you think?
Well, the CSF is under research in this condition. Still, there is no strong evidence about any possible underlying mechanism. And also, the radiological studies exist in the literature. For example, the brain gray matter volume measurements, they were performed by Regus and colleagues, and it's defined as a risk factor for the development of the PLE in the patients with the smaller gray matter volumes. But for a future research, I cannot answer it now.
Okay, thank you. Thank you for this answer. I give back the word to the pro-rector.
Thank you very much. Then the opposition will be continued by Dr. Janssen. He is Associate Professor in Neurology and Clinical Neurophysiology at our university, and I'd like to give him an opportunity to discuss with you.
Thank you, Mr. Pro-Rector. Dear Mr. Candidate, first of all, I also would like to congratulate you and also your promotion team with this excellent thesis. I think this really adds insights for the functional neurosurgeon to optimize stereotactic surgery for deep brain stimulation. Before continuing the opposition, I first would like to ask one of your paronyms to read out loud proposition number 8.
8?
Yes.
Science and art leave the societies in which they are not respected.
So, Avicenna is a medieval philosopher who made this statement. Do you think this statement is timely?
Esteemed opponent, thank you for your nice comments and question. Yes, I think his word is timely, and it is actually timeless, I think. In the past, it was also applicable to the society. This is also can be generated to the other fields other than science. But in my opinion, it's an important point because for growing a plant, you need the right environment. And that's a very nice explanation for this, I think.
I completely agree with you. Avicenna, actually, he was a famous figure, and he was one person who had also a sophisticated theory on how the senses actually interacted with the brain, and that the brain actually was the central organ where sensory information was processed and where it interacts with reason. And what we're actually doing also with deep brain stimulation, I think we are interacting with these brain processes. Having said so, as a neurologist, so I'm always happy if our neurosurgeons have low complication rates and if they put the electrode where it should be. And you address this, I think, also in chapter 3. And in chapter 3, you compare two methods, so the indirect method and the direct planning method. And you nicely show this also during your presentation. You show that there are less electrodes, microelectrodes used during the procedure. You also state that more often, at least, there's a tendency that more central electrode is used. And do you think this shift, did this also result in less complications?
Thank you for your question. The aim of this study was just to find out the final electrode position with the shift from indirect to direct targeting method. There was not a second outcome of the study in terms of the complication rates directly, like hemorrhage. But for the targeting, if you're mistargeting, this can induce the stimulation-induced side effects mostly, which we do not want because our therapeutic window gets narrow. And in the advanced stages of the disease, for example, initially we can get the desired motor effect, but with the progression of the disease in the near future, we cannot be achieving the same effect. And our window will be narrow, we won't be able to play around the amplitude and the other parameters. So that's why it was important to place the electrode exactly what we desire, where we desired to place.
Yes, indeed, you show that indeed the coordinates for the final electrode position shifted a bit. And then actually, I was a bit surprised in your general discussion that these findings, this is what you stated in line number 4 on page 94, these findings demonstrate the clinical benefits of the direct targeting method over the indirect method. Is this really what you have shown in chapter 3?
Okay, thank you. Well, in terms of clinical efficacy, we haven't measured it. But we just measured the laterality and the centrality of the electrode. But at the end, that statement actually means that we were more compatible with the electrophysiological findings intraoperatively. That's an indirect predictor of the postoperative motor outcome. So why is this important is nowadays more and more clinics are shifting to a sleep DBS. So in the sleep DBS era, even some clinics, they stopped using MERs. They're only directing using the MRI vision and also combining it with the classical indirect targeting coordinates. So this study is paving the way for the teams who will decide to perform this DBS surgery under general anesthesia mostly, and they will know that they hit their desired target in more than 60% of the patients.
Yeah, so I'm very happy that you addressed this point, and that you also like to use microelectrode recordings. As I'm, of course, a neurophysiologist, I'm really also fond of this, and also I think it really contributes in especially the dorsoventral axis of the placement of your electrode. So if you now have the opportunity as a neurosurgeon to optimize your preoperative plan and also your intraoperative plan, so what kind of imaging methods and intraoperative methods would you use to optimize your electrode placement?
Thank you. Some teams use intraoperative imaging recently. The basic one in general...
Yeah, but which one would you choose? So what would you do before surgery? What kind of imaging modalities? And during the surgery, which one would you choose? I mean, you've learned a lot during the last decade, and now you're the one to decide.
Okay. My personal point in this is pre-planning with MRI, but not only with the classical sequences, but also including the tractographic data, and also the novel sequences like FGATIR to see the capsular areas and comparing the borders of the nuclei in a better way. And then intraoperatively, I prefer to fuse it with an intraoperative CT, because recently the fusion functions of the softwares are developed. Maybe 10 years ago we weren't so much relying on it, but nowadays I can rely on it.
Thank you for your answer.
And as you noticed, the Peter came in exactly on time, and I would like to thank him, and I think we came to a conclusion. Mr. TÖNGE, the time appointed for defending your thesis has now officially passed. The degree committee will now withdraw, and we're going to discuss not so much the quality of your thesis that has been approved, but we're going to discuss your presentation and the way you have defended your thesis this afternoon. And I would like to request that you and your company here available in this audience await the results of our deliberation and return to the aula. Thank you very much.
The PhD defense has now ended. The degree committee will debate the candidate's performance behind closed doors. This process usually takes about 10 minutes.
Long road to the south side. 7 miles in my rearview mirror, I know what it felt like. My goal's only getting clearer, east side to the west side. No place like home, if it's questions that you've got, go the extra mile and die. Your mind, years can't fly by now, don't waste all your time, cause I'll go the extra mile. Long road to the south side, 7 miles in my rearview mirror, I know what it felt like. My goal's only getting clearer, east side to the west side. No place like home, if it's questions that you've got, go the extra mile and die. On the dash, got my laces tied. Long road, I don't waste no time. Break rules because fate decides. With the team and we chase the light. I make a move, fall down, shake it off. I hate to lose, bad branch, break it off. No room for negativity, praise and love. Prepare for deep part cause we're taking off. Hit the mileage, traveling so far from home. Gathering knowledge, other connections. I put the time in to get everything I ever hoped for. It's a challenge and we all in. It's a better future that we go for. And even though these nights seem long, I know that I am never on my own. Know you've won the battle once you've grown. South side, 7 miles in my rearview mirror, I know what it felt like. My goal's only getting clearer, east side to the west side. No place like home, if it's questions that you've got, go the extra mile and die. Long road to the south side, 10 miles in my rearview mirror, I know what it felt like. My goal's only getting clearer, east side to the west side. No place like home, if it's questions that that you've got. Go the extra mile or not. What's on the line? I know you know that I can't read your mind. Years can't fly by now, don't waste all your time. 'Cause I'll go the extra mile.
Dear Mr. TÖNGE, the degree committee here present has assessed the quality of your thesis, but in particular the way you have defended your thesis this afternoon, and also taken in consideration the presentation you've given to all of us. In view of its positive verdict and taking into account your previous qualifications, the degree committee has decided to grant you officially the degree of doctor. Professor Timel is authorized to confer upon you this academic distinction in according to Dutch university customs, and therefore I invite now your supervisor to take the floor.
Please all rise.
Do you promise to work in accordance with the principles of scientific integrity at all times, to be careful and honest, transparent, independent and responsible?
Yes, I promise.
By the authority vested in us by law and in conformity with the decision of the committee here present, I hereby confer upon you, Mehmet TÖNGE, the degree of doctor and grant you all rights attached by custom and law. As evidence of this, I will present you with the degree certificate signed by the rector, the secretary, and the other members of the committee, and affixed with the official seal of the university. Mehmet, congratulations.
I give the word to Professor Timel for speaking out the official laudatio.
Yes, you know, with the PhD there is the laudatio, and laudatio we get personal. Dear Mr. TÖNGE, dear Dr. TÖNGE, congratulations on receiving the doctorate. You have now officially obtained your PhD degree in medicine from Maastricht University. We are very proud of you. It took us some years, and I would like to go back a little bit in time. You know, we say, the ones who guide PhD students, that each PhD has a story, is a journey. And your journey started somewhere in 2008 or 2009. I don't remember well, but it was a course that we organized in Samsun. It was actually a neuroscience course, a stereotaxy course. You came there as a resident, young resident in neurosurgery from Ankara, and already we noticed from all the people there that you had a particular interest in neuroscience. Although you were a resident in neurosurgery, your interest in neuroscience was actually greater, larger. You were also one of the persons who, after getting in touch with us, with the Maastricht neurosurgery neuroscience community, after finishing your residency and becoming a neurosurgeon, contacted us to do a fellowship. You came to us, and your interest in science was actually had grown even more. So I think somewhere in Samsun you got the science virus. And the science virus, started to replicate itself in your body, and then reached the curiosity areas in your brain, and then actually resulted in approaching us for an official fellowship. You were in the lab with Dr. Jahan Shahi, and you really both worked on an experiment, and you did a lot of neuroscience in the lab. And besides that, you're also involved in clinical research. That was actually the basis or the foundation for your PhD, who has now actually been completed. You started to formulate, when I look back and look at your development, at some point, and it was actually somewhere, I think, at the end of your period with us, you started to formulate your own hypothesis. designed your own research, and collected data. And you wrote your scientific articles. You published 4 papers with us. These are nice products of our collaboration. And we have also trained you in deep brain stimulation surgery, Mehmet. You know, you are one of the few people that I trained myself and were active in Turkey then. And you became an independent DBS surgeon and you started your program. And I'm really, really proud of that. Mehmet, I know you as an honest, smart, if I say I mean speaking also for Ali, we know you as an honest, smart, hardworking academic. And above all, he's a true gentleman. My advice is that you keep combining these characteristics in your further career. I hope that you will pass the virus of science on young people. And that you become a source of inspiration for others in your environment. And now, a Turkish line for you. Sevgili Dr. Tönge, bilim evreninde yolun açık olsun.
Dear Dr. Tönge, may I ask also one of the first one to use now the official title you have earned. It is basically in the Netherlands the highest degree which you can get. I also would like to congratulate you, also on behalf of Maastricht University, of our board of directors, and my congratulations, of course, is also your promotion team, which have guided you over so many years that you finally could stand here and perform and show what you have learned. I also would like to thank the members of the Corona who had the time here, come from Turkey, from Maastricht, read your thesis, formulated some questions, and addressed them to you here. And my congratulations also your family who is here. And it's nice to say that you're here, that you took the effort, took the time to come all the way from Istanbul back to here to Maastricht. Some personal notes. I remember quite well when we met in 2009 with Professor Suleimai Kaplan in the neuroscience course at that time in Samsun. And I've been back in Samsun at that time. I was intrigued by your front cover. Not so much about the title, I'm not going to discuss that, but I saw the picture over there. And the picture is some work what you did at that time, I think, and you stained with the transgenic Huntington disease rat, which was rather uncommon at that time to get, and you look for dopamine cells, I think, in the substantia nigra. And of course, I was pretty disappointed that if I read in your front cover image that you said these are TH positive cells, which are dopamine positive cells, which is basically the competitor for the people who work in the neuroscience field. So basically, it was nice to see that you have grown in this respect. And I do hope that you can include what you mentioned at the beginning, that you include research in your professional neurosurgery department, which you like to have included. Saying this, I think it's time now to celebrate. And for the celebration, I would say we have a small audience, but we still have some coffee, even some wine, if it's allowed, some nice things, because it's hot weather outside. We are going to make a picture on the stairs of the university, and I would like to invite your family to join us for the picture, yes? And you don't have to wait for us, and we're going to meet in the rafter inside, yes? And by that, I'm going to close this session officially, and we're going to meet there in about 7 minutes.